Dr. Darden made mention that she's in the waiting room.
I've disabled the waiting room, so there shouldn't be anyone in there. Is she sure she's in the right meeting?
It's the link that I sent her that everyone else used.
Okay, Lynette, are you ready to get started?
Chairman, I am. And I have the agenda up. And I will take roll quickly. Robert Cowles, are you present? Robert Cowles? Okay, and Roger Folsom did indicate, Chairman, that he may not be in attendance this morning.
I'm present, Lynette. Thank you.
Oh, awesome. Awesome. Shane Mobley?
Shane is on. He's
here.
Oh, there he is.
Can y'all hear? Yeah, sorry. It said, and Dr. Coles might be having this problem too. It said that the host is not letting people to be unmuted. So
Dr. Cole should be able to unmute himself now.
Okay. Because I think I saw him on it.
Right.
All right.
He is here.
Okay. All right. So he's accounted for. And Dr. Cynthia Rucker?
Here.
All right. Are there any other board members present?
All right, we'll go ahead and get started. So thank you for that, Lynette. We'll call our Care Management Committee meeting to order. We all have the minutes that were sent out to us from our last meeting in August, where we focused on some updates on redeterminations for Medicaid, Peach Care, and also an update on pathways to coverage with the 1115 waiver. And then also Lynette provided some information on provider revalidation. Could I get a motion to approve the minutes, please?
Roger Folsom, motion to approve the minutes.
And a second?
Cynthia Rucker, second.
Okay, thank you. All in favor of approving the minutes, please say aye.
Aye.
All right, thank you. All right, so our minutes from our August 10th meeting are approved. We will now move into our agenda where we've got, it looks like a pretty full agenda with the presentations we have that were sent out to us. So Lynette, I will turn it over to you to begin our general updates.
Thank you, and good morning, committee members. My updates today will be just high level so that we can have adequate time to walk through the presentation from Dr. Holloway and also the medical directors for our care management organizations. But as it relates to the Medicaid redeterminations, we are now in month 6. So we are halfway through, halfway there. We continue to complete the redeterminations on a monthly basis. Thus far, since the beginning of the process in April, we have renewed coverage over 400,000 individuals, which is great. In the months of September and October, we were able to automatically renew a little over 31,000 individuals. So if you will recall, for the committee members, I grouped them into 2 buckets. So bucket A are those who could be auto-renewed, which means, again, they don't have to provide any information at all. We will utilize our external resources and data interfaces to try to glean and obtain as much information as possible without the member having to provide any information. So utilizing that auto renewal process, we've been able to again automatically renew a little over 31,000 individuals since we started this process. And then for those who don't fall within that group, who we are unable to auto renew, we've issued notifications to those individuals, again instructing them to go out and to complete that renewal process. We continue to try to focus on increasing the number of individuals who can be auto-renewed. So we're continuing to work on that process through our partners at DFAX and also our consulting firm that we're working with. So just want the committee to be aware that that process continues. We will share updates at the next quarterly meeting that we have with this committee. But if you have any questions, of course, I will respond to those. As it relates to provider revalidation, we talked about this at our last meeting. And so again, just as a refresher, federal regulations require all state Medicaid agencies to revalidate the enrollment of their providers. And so we started this process in September. We had actually put the revalidation process on hold during the public health emergency, but remember that ended in May. And so we have now reinstituted and again have started completing and walking through that process. Since we've started in September, I am excited to report that we have had over 20,000 provider locations to complete the revalidation process. And so that's awesome. We have extended the deadline for providers to complete the revalidation process. The new deadline is now December the 31st. And I'll repeat that. The new deadline is now December the 31st. So we're going to allow providers until the end of the calendar year to complete that process. And chairman and committee members, we will continue to work with the various provider associations to help to get the word out. We are also posting information on the GAMIS website as a banner message, informing providers of the new deadline date and also frequently asked questions and other information that they can access to assist with the process. So those are my two updates, Chairman, and I will pause now for any questions from the committee.
Thank you, Lynette. Does anyone, any of our board members have any questions for Lynette on those two updates?
Yes, Dr. Coles, can you hear me okay?
Yes, go ahead, Dr. Coles.
Yeah, as one of those providers, I was curious. I'm going to actually have to check with my staff about that, but do you send out a notification by mail to each practice or physician that participates in the Medicaid?
Yes, we do. And we've sent out notices informing providers of the deadline dates. And we are going to be sending out another batch of notices informing them of the extension through the end of December. But yes, is the answer to the question.
Great. Thank you very much. Appreciate that.
Okay.
And then Lynette, one question from me. So you mentioned the deadline is 12/31. So does that, just for clarity, does that mean any provider who does not complete the revalidation prior to 12/31 will no longer be able to participate with Medicaid until that is completed?
That's correct. So what will happen is on January the 1st, those providers who did not complete the revalidation process, who are on the list, and I do want to remind everyone that there is a list of providers that's posted on the GAMIS website. And so if you are on that list and you do not complete the process by December the 31st, on January the 1st, your enrollment status will be suspended. You will go into a suspended status, which means that you will not be able to submit any claims for reimbursement with dates of service beginning January the 1st up until you actually complete the revalidation process. So Chairman Williamson, what happens is it'll be that individual provider, practitioner, or facility will be suspended as of January the 1st. And then they will need to complete that process to get reinstated. But during that window of time in which they are suspended, if we receive any claims with dates of service beginning January the 1st, which is the date of suspension, through the date that they complete the revalidation and reinstate, those claims will not be paid. And that applies to claims for fee-for-service or traditional Medicaid, as well as any claims for managed care services.
Okay. Thank you for that additional clarification. I thought that was the case, but I just wanted to kind of have that added clarity. Are there any other questions for Lynette?
I do have a comment, not a question. I really appreciate hearing that the number of those who can be auto-renewed, or you all are still working on that, trying to increase that listing. So that's encouraging to hear.
Absolutely. Thank you so much. Yes, we continue to meet and try to find ways in which to increase those numbers. So we'll keep the committee posted and share, more detailed information at our next quarterly meeting, which will be in 2024. So with that stated, if there are no further questions, Chairman, we have a presentation for the committee today that will be led by Dr. Holloway, as well as representatives from each of our care management organizations. And Dr. Holloway, I'm going to pull up those slides now.
Thank you, Lynette. And Dr. Holloway, we'll turn it over to you to kick us off here.
Good morning, and thank you, Chair Williamson, as well as good morning to the rest of the committee members. We're delighted to be able to have a conversation with you this morning as pertains to DCH and addressing health disparities. And as we go to the next slide, and as we strive to do so as relates to providing and living into our mission of providing access to affordable quality health care for our beneficiaries and Georgians, we certainly do that in partnership with our care management organizational plans. And we're delighted to have with us this morning medical leadership from the three plans within the state. For CareSource, Dr. Sumasukas, as well as Dr. James Richardson from Peach State Health Plan, and from AmeriGroup Community Care, Dr. Arden. They'll have an opportunity to greet you when they get to that portion of the agenda. And what I'd ask is that if we can hold questions to the end so we can afford them time to go through some specifics regarding their plan activities. But what we wanted to do this morning is to provide an overview as it pertains to health disparities. Just in general, what are some of those drivers that actually lead to health disparities within populations, and then focusing in on maternal outcomes, specifically in the state of Georgia. The health plans through the medical leaders will touch on initiatives and projects that are in place within the state to be able to close that gap within the populations, specifically around maternal outcomes. So next slide, please. Thank you. So just in terms of an overview, what really are health disparities? Health disparity really talks about there being a difference in outcomes between groups within the population, and specifically whether it's unjust or not. And what does that really mean? Say, for instance, if there's a genetic predisposition for certain outcomes, be it sickle cell. However, health inequity speaks to those differences in populations that are structural in nature, systemic, avoidable, or essentially unjust. And certainly at DCH, we take a look at metrics that give insight into these disparities within our populations and how we proceed to progress toward closing those gaps to ideally achieving health equity. Next slide, please. We know that there's significant evidence of health disparities within populations, not to go into the details, but these are just examples of some that we probably are fully aware of. Next slide, please. And when we talk about the domains of drivers to those health outcomes where there's disparate outcomes, we know there are economic challenges. Where you live does make a difference. Your education, certainly in regards to access to healthy options as far as food, but also in terms of social context. Certainly within the healthcare system itself, be it in terms of access to care, coverage, but also implicit biases as far as biases within providers certainly makes a difference. So indeed, there is certainly a social and economic component that drives inequities. Next slide, please. When we talk about maternal care in terms of access, this is a illustration for our counties in the state of Georgia, 159, and those that have been designated as maternity care deserts. That is in those counties in which they're without obstetric services or birthing centers and the associated providers. But also it takes into consideration where there are a higher percentage of childbearing women that are without health care. So when we think about the 159 counties, 35% of those counties are considered deserts. And we see within the relationship to the rest of the country. And about 50% of predominantly Black counties are maternal care deserts. And it's approximately 21 counties in the state that constitute predominantly Black counties. There have been significant closing of labor units since 1994, and more so in Black counties. There are about 35% of the total population in the state are made up of Blacks, and about 25% of Blacks live in counties without or little access to care. And we see also there's a large percentage of counties with a higher percentage of women without health insurance, because that does make a difference when we see in terms of birth outcomes, women that have health conditions are much more likely to have preterm births. So with that as a backdrop, I'd just like to share this illustration before we turn things over to our medical leaders of the CMOs. If we go to the next slide, please. This is just an illustration, and please indulge me, but it's just an illustration that speaks to how best to approach disparities. If you certainly take a look to the far left of what the landscape looks like, with the fence representing barriers, all populations are not the same as relates to their barriers and having access. If one applies or approaches things equally for everyone in the population, that still doesn't address those persons or those populations that started out a little behind or much more behind than others. Equity requires addressing resources in a targeted approach to truly ensure that indeed outcomes are as we desire for all populations. With that in mind, and we would like to certainly now turn it over to our CMO medical leaders, starting with Dr. Sukas and CareSource.
Thank you, Dr. Holloway. Good morning. I hope everyone can hear me okay.
Yes,
Yes,
ma'am.
Dr. Sukas. Yes.
Okay. So I'm Seema Sukas. I'm the Chief Medical Officer at CareSource. Thank you for having us present today about maternal health, very important issue across the state of Georgia. If you could advance the slide to the next one. I think for us, first of all, we need to know who are our pregnant members. We have approximately 29,000 pregnant members each year in our health plan. Most of them are between the ages of 22 and 30. We have pregnant members across the state of Georgia, but they are concentrated in the metro Atlanta area, in the Macon central part of the state, and in the northern parts of the state. And as Dr. Holloway mentioned about chronic conditions, we do know that many of our pregnant women have chronic conditions, most importantly, obesity, hypertension, and diabetes. Next slide, please. We also know that Georgia has a very large problem with maternal deaths and infant deaths. We do track the deaths within our health plan. The dark blue shows the deaths for women. And overall, we've seen a slight decrease in maternal deaths over the course of our health plan's time in Georgia. But we do know that Black women have higher rates of death than the white women. Also on this slide, you see infant mortality. That has also decreased, but slightly more deaths for Black babies than white babies. Next slide, please. We also know that preeclampsia and eclampsia are high risk factors for maternal deaths, and this is just addressing high blood pressure for pregnant women. We do know that Black women have higher rates of these diagnoses than white and other races, and this is a factor along with the other data that we consider so that we know where to focus our energies, our resources, our information when we get new members, pregnant members into the health plan. Next slide, please. We have a Mom and Baby Beginnings program. This is basically a team of individuals in our health plan, made up of a pretty diverse group of individuals. We have nurses, we have nurse practitioners, we have lactation consultants, we have behavioral health specialists, social workers, and others that really wrap around the care for the members that are pregnant. We reach out to each one of our pregnant members to do a risk assessment, and that risk assessment includes not only understanding what their medical conditions are, but understanding, do they have any behavioral health conditions, and what does their environment look like? Do they have housing instability? Do they have food insecurity? Do they have family support? All those things factor into assessing the best needs for that member and how we best support them. We certainly want to make sure that they have a provider that they are seeing for their maternity care, but we also provide them information about what happens in the course of their prenatal care and their postpartum care, and enroll them in any incentive programs or value-added benefits that may be available to them. We communicate with them not only by phone, but also in lots of different ways: text, emails, regular mail. All those things are important. And through those various communication means, we're able to provide them information on prenatal care, postpartum care, incentives, well baby checks, because we know they're going to have a baby and what to do to prepare for that infant. We also want to make sure that they have access to services. As I mentioned, we do connect them to an OB provider, but even in the postpartum period, sometimes they're not going in for those postpartum visits. So we do have access available to a nurse practitioner that can do postpartum telehealth visits. All of this is important, and we know that we want to make sure that our women are healthy, but health and well-being is about more than going to the doctor. It's about all the community resources that are available to them and supporting their care. And we partner with a number of community partners to help wrap those services. So I'd like to go through a couple of those partners. Next slide. We have a partnership with Walmart and Johnson & Johnson, specifically focused on maternal health. Couple of ways that we have leveraged this partnership. Number one, we do provide education for our physicians about maternal health. It is free continuing education credits that they receive, but the training includes information about cultural competencies, about unconscious bias, and how they can improve their practice and their practice environment to support women of all races and backgrounds. We also provide access for our members to a digital platform. So in between their visits with their healthcare provider, they can access the digital platform at georgiamamacare.com, and they have access to, again, an array of professionals who can support them: nurses, lactation consultants, behavioral health specialists, et cetera. So it provides additional care in addition to what they're getting in the OB office. We've also done a couple of mom and baby fairs at select Walmart locations. We looked at locations where there were a lot of our families that are in the general area. And at these mom and baby fairs, it's supposed to be fun. It's supposed to be an opportunity for families to learn more about pregnancy care, about well baby care, about postpartum care. We also include many of our other partners, community partners, in these events as well. So families are getting information, they're getting resources, and learning more about how to take better care of themselves during the course of their pregnancy and postpartum visit. Next slide. Another partnership we have is with the HEART program. This is a program that provides training And it's based on a community health worker training curriculum, but basically the folks that go through this training become certified family health advocates. We started this in Clayton County. It's expanded across the state of Georgia and also into North and South Carolina. So far, 70 people have been trained, and they are now certified family health advocates. And these are individuals that are not clinicians, but are folks that can provide additional support for pregnant women and their families through the course of their pregnancy and beyond. Next slide. We also have a partnership with Phoebe Health System where they've implemented the Nurse Family Partnership Program. This is a national program that provides support for first-time, low-risk pregnant women and works with a nurse in the family through their pregnancy and up to 2 years after delivery. So the program has started in the Albany area, and they have so far 72 clients enrolled in the program. We've also done some maternity fairs in the Albany area to, again, provide resources, information, and support for families. Next slide. And I just want to close by talking a little bit about some of the information that we collect. We're always collecting data. We want to understand our data. These are two of our data points, looking at timeliness of prenatal care and timeliness of postpartum care. And we are seeing a slow but steady rise in the compliance for both of these particular indicators. We look at lots of other data as well, but we also consider the voice of the members. We consider the voice of the providers and the voice of the community. All those perspectives are important along with our data, and that is what we use to continue to review our information and our supports to make sure that we're providing the best care possible for our women through their pregnancy and postpartum care. And with that, I will close out and turn it over to Dr. Richardson.
Thank you, Dr. Sukas. Good morning. Earlier, Dr. Holloway defined health disparities and also shared some of the measures of health inequalities, such as life expectancy and birth weight, prematurity, and other conditions that can be seen in differences in race and education, and of course, location, that's rural versus urban. Peach State, we are always committed and have been committed to improving the health and wellness of the Georgians we serve. And we also understand that the social and economic inequities and health outcomes are inextricably linked. First, let's take a look at Peach State's current state. And this is a review of our pregnancy population from the end of last year through current. We've had almost 21,000 live deliveries. Almost 90% of those were women of 21 years of age or older. About 50% of those were Black or African American, and 40% were white women. Atlanta had the highest number of deliveries, followed by the Central Region. The American Indian and Alaska Native had the highest compliance with postpartum visits at 61, almost 62%, as well as some of the other Native Hawaiian and Pacific Islanders. They had lower at 33%. The reason why these statistics and these measures are important, that it allows us to focus all of our efforts into where needed. In other words, we could not give the same services to each group because they all have different needs. And I think the slide that Dr. Holloway showed with the, with the cartoon of the three different definitions sort of indicates that. Next slide, please. So what is Peach State doing to address health disparities? First, education. We know that that is a major part of that, and I'll talk about the Start Smart program for your baby shortly. But next is care management support. And that includes managing our high-risk OB members, and of course, for us to determine that screenings are required. Access to care. We want to make sure that not only our members get in to see their OB provider, but they get in early. And as I said earlier, social determinants of health. If those are not addressed, then it's very difficult to have good outcomes. And timely follow-up care, as well as cultural competency, meaning they have to be able to talk to the pregnant moms that they're serving. I'm going to go through a couple of the programs. You can stay on that same slide for now. First, Start Smart for Your Baby program is something we believe that will lead to and leads to healthier pregnancies and good prenatal care. It's important to first identify a pregnant member as early in the pregnancy as possible. So I'm going to walk you through how members come in to us, how we determine that they're pregnant, and then what we do about it. So first, we receive pregnancy notification from either the state membership file or from county health departments or from NOP. NOP stands for Notification of Pregnancy. That's a program we use to incentivize both providers and members to let us know as soon as possible that pregnancy is there. That once we know that, many things happen. First, we do outreach. Our care management team goes in and does a screening. Not only do they screen for health conditions, but they also screen for the social determinants, and any needs identified, they are referred to both either state agencies or some of the community agencies. Within the Start Smart program that we use, the other thing is we have something called baby showers. And what is that? That's group community events that allow new moms, expectant moms, and some of the older moms to commune together and share best practices. We know that this really leads to better compliance with recommendations and better outcomes. We also have a 24/7 advice line for these new moms to call in. And we think all of these supports are significant and needed. And again, we continue to do that. I talked about the notification of pregnancy, and I say that notification of pregnancy early as possible is what leads to the best outcomes. If you go to the next slide, here we show the trends of low birth weight babies, those that had a notification of pregnancy versus those without. And it's been very consistent that those that have submitted a notification of pregnancy, whether it's through the provider, which is about 2/3, or through the pregnant member, which is about 1/3, there's about a 30% improvement or decrease in low birth weight babies. And we'll continue to use this process. And again, as I said earlier, is better. Next slide, please. Here we talk about when we receive the notification of pregnancy. In 2020, it was more second trimester, and as of this year, significantly more in the first trimester. Again, remember, earlier the better, and so we're making progress. To encourage that, again, we have incentives, financial incentives for both members as well as providers, as well as education with the members. So we talked about how we identify the members. We talked about how once we identify them, we screen them for both medical needs and social determinant needs. And then what happens after the baby is born? Well, we have other programs that we use to ensure that the mom has good outcomes as well as the baby. We have Planning for Healthy Babies, which of course is inter-pregnancy care services, and that is essentially educating moms to what works for them from a standpoint of next pregnancy, and as well as using resource mothers, and those are trained assistants that help these new moms with navigating all the things that a new mom needs to do. In addition, to help the new moms out, we have what we call value added benefits. And that includes, all the things that we know that are important. We have a new mommy store, electric breast pumps, mom's meals. We know that many have food insecurity. And of course, we have other services to keep our moms and babies healthy. Next slide, please. And this last slide shows one of the efforts of postpartum intervention, part of the CPI group. And this talked about how could we improve postpartum care rates in the East, the Southeast, and Central regions. These are some of the interventions we used. For the East region, we sent flyers, we emailed to the OBs, OBGYNs, sharing the availability of incentive for completing a postpartum visit. For Central, we also had some of our quality practice nurses visit the OBs to talk to them about the importance of making available the postpartum visit. Of course, the standard is between 7 days and 84 days. And our goal is to make sure that that standard is met. And similar efforts in the Southeast region. Earlier in the presentation, it was mentioned how some areas have a desert when it comes to OB care. Peach State, we're on year 3 of a partnership we have with the Augusta University that develops OBGYN as well as other primary care specialties to work in rural areas. And after they do, we call it the 3+3 program. After they do 3 years of medical school, 3 years of residency, then their loans are forgiven if they work for 2 years in these rural areas. And we know that's making a difference. We're on our 3rd class now, and we'll continue to do those impactful efforts like that. And that is the end of my presentation. Of course, at the end, I'll certainly take questions, but I'd like to hand it over to Dr. Darden.
Good morning.
Good morning.
Morning.
Thank you. Just making sure that my audio is great. Thank you for the opportunity to speak to the board and specifically about AmeriGroup and some of the initiatives that we are doing relative to maternal child health here in the state. My name is Trudy Darden, as mentioned, and next slide, please. We've already, from Dr. Holloway and my fellow colleagues, talked about the health disparities and health equity issues that we're facing. Our focus today is talking about how we're addressing some of those areas, particularly areas with access to care, inequities in care, and access to nutritious food. Next slide, please. One of our initiatives has been the establishment of a doula program and looking specifically with a pilot that launched initially in April of 2022 and has been now relaunched after showing success in the program. Specifically, the doula program, as you know, provides lay support to our pregnant mothers. The program has the 2 prenatal visits that are part of the initiative. There's labor and delivery support, and then postpartum support for 2 postpartum visits, and breastfeeding support that's also offered. Next slide, please. When we look at what essentially has occurred and what our outcomes have been, we can truly say that when we compare 2021 to 2022, and recognizing that in 2021 we had roughly 16,000 pregnant mothers, in 2022 we had roughly 18,000 pregnant mothers. The doula pilot essentially showed us that we were able to see through this and other, of course, initiatives, a decrease in our primary cesarean delivery rate. We saw that from 2021 to 2022. We also saw the compliance rate postpartum, meaning those mothers that were coming in for their postpartum visits, that was also showing an increase from 2021 to 2022, and that our morbidity rate overall for at least 42 days postpartum had also reduced. We saw low birth weight going down as well. And again, while we don't contribute all of this to the doula project, we can make some association with the initiation of the doula project and some of the outcomes that we're seeing here. Next slide, please. When we look at the doula program, we've had targeted enrollment of 225 women, primarily in the southeastern rural counties and metro Atlanta. 40 doulas have been trained in the Valdosta and Savannah area, and we've used our geographic analytics to determine where to start our training, and those were the areas based upon the amount of chronic conditions such as diabetes and hypertension and some of the morbidity and mortality rates we were seeing in those areas. 21 doulas have been credentialed and hired. Those doulas are certified. They have their first aid and CPR training, level 2 background screening, and HIPAA training. And while they have been recruited, trained by a Mary group, they are doulas for any potential member, any potential patient in those areas. The diversity of the group is pretty cross-cultural, with African American, Latino, and Caucasians represented. And in October of this year, we started and relaunched the program with 20 members starting out. And again, this has been just a few weeks ago, so we'll be looking at that outcome data on next year. Next slide, please. The second initiative is around the conditions of diabetes and hypertension and the effect that it has on our pregnant mothers. A program that we've launched in June of this year called Mom's Heart Matters, MHM, is really a remote patient monitoring program with the focus on the group most impacted by hypertension, and that is our Black and Brown mothers. We launched this program a few months ago, and in a moment we'll see some of the positive outcomes that we're already seeing. Our objective was really to reduce the rate of hypertension-related mortality among pregnant and postpartum women, to meet some of the ACOG guidelines for perinatal postpartum blood pressure readings, and to improve the likelihood that women will be seen by a cardiologist if and when needed, and to reduce ER visits and inpatient admissions. The services that are provided include the remote patient monitoring, the non-connected device program. The member actually does her own self-monitoring, and then the education and resources provided to manage hypertension. Next slide, please. Our outcome data, which is, again, just a few months in the making, we've had 87 women enrolled, and of those 87, 76 are pregnant and 11 are postpartum. Next slide, please. Of those members, we've had 990 total readings, so almost 1,000 readings, and again, just launched this a few months ago. And 376 of those readings were at or above hypertensive crisis readings. All of those members received live outreach from our vendor. 108 of those were escalated to their primary care provider and received a follow-up call from our vendor within 24 hours. Next slide, please. Part of our excitement about our maternal program was what we had seen in the physical health program. And just to show you, because this program launched over a year ago, and we saw the very positive outcomes with our non-pregnant population, where we had over 59,000 readings, 10,000 of those readings were at or above the hypertensive crisis. All received live outreach and vendor notification, and 699 of those were escalated to their primary care provider and received follow-up calls from our vendor within 24 hours. So based on the amount of activity we had in that program, we knew that we could see some potential benefit from our maternal population because of the success we had seen with our non-pregnant population. Next slide, please. An additional program that has been initiated, launched in September 2021. We've continued this program throughout. This was our Mom's Meals program, which provided nutritionally tailored diabetic-friendly meals to support women diagnosed with type 1 or gestational diabetes and who may be at risk with their pregnancy. The program goal was to provide women with the nutrition needed to support their own health, as well as the health of their baby. Specifically, after enrolling into the program, the members are provided 2 refrigerated meals per day, 14 per week, up to 10 months. These meals are delivered to their doorstep, a modified DoorDash, if you will, or Uber Eats, within 5 business days after receipt of the referral. Next slide, please. What we've seen is that since our inception of this program, there have been nearly 42,000 meals delivered. Year to date in 2023, we've had 14,000 almost delivered, 13,791 meals. And we have seen some of the outcomes of this initiative showing reduced medical claims spent for moms, reduced inpatient admissions, reduced outpatient admissions. And again, we know this is multifactorial, but we've seen a direct correlation between the initiation of this program and some of the data that we've seen in terms of outcome. Next slide, please. And in summary, what AmeriGroup continues to do is really impact the maternal child health communities through the wellness and chronic disease management. And hopefully we've demonstrated some of this through the programs that we've discussed this morning. That concludes my presentation, and certainly I'm open to questions or other observations. Thank you so much.
I'd like to thank Dr. Sukas, Richardson, and Darden. Chair Williamson, we turn it over to you, sir, for any questions, answers the committee and others may have.
Well, thank all of you for putting this information together for us. It was very comprehensive, a lot of useful background data on the challenge of healthcare disparities that we are facing, and then a lot of good information on focused programs and initiatives, some innovative ideas on how to address these disparities. I'd like to open it up to our board members to see if they would like to ask any questions of our presenters this morning.
Thank you. I would like to ask a couple of questions. This was really good, and I really appreciate, first of all, I want to say that learning about the initiatives, because I didn't know about most of these. Dr. Sukas, I'm sorry if I'm saying it wrong, but related to the mom and the baby beginning, could you talk a little bit about the communication? Is most of it in person, or is it half and half? Is it televisits, or I was just curious about that.
Sure. It's a little bit of all of the above, and it depends. Certainly we start out with telephone communication. We do have folks that are located across the state of Georgia. So depending on the family, if they feel like they want an in-person visit, whether it's in the home, the local library, et cetera, we provide that as well. So it really is tailored to the needs of that individual member. But it could be just, we have some women that are maybe in the younger age that like the electronic communication. So we do, text and email. So it really depends, but all of those options are available.
Thank you. Thank you so much. And Dr. Darden, I really appreciate hearing the initiatives and the outcomes. The doula program, when did you say it actually started?
Yes, the doula program was initially launched in 2022. We relaunched it in October of this year.
Okay, this is
It was a pilot in 2022.
Go ahead. I'm sorry.
I was indicating it was a pilot program in 2022. And because of the success of the program from our perspective, we relaunched it as a permanent program in October of this year.
Thank you both.
Thank you, Dr. Rucker, for those questions. Any further questions from our board members this morning?
This is Shane. Mobley. I don't have a question theoretically, but I want to say it was an excellent presentation. I really appreciate all the hard work, again, that was put into this. And, I have a lot of rural care experience as well. And, we talk a lot about access and things that we're having in Georgia, but, what about personal accountability? Because my experience that I've seen, we would have many pregnant mothers that would come into the ER having a baby who refused to go to the doctor for the entire pregnancy and knew they were pregnant. So, we can talk a lot about access and we can talk a lot about these different things, but I think there's a general mistrust in many communities of the healthcare system. I don't know very many people, including myself, that have unconscious bias and are sitting back and not wanting to take care of patients. I think we all want the good for humanity. But I can tell you, as one of the largest providers in the rural communities in Georgia, the issue is getting patients to come. Many of our patients that are in the Medicaid programs, they're our most non-compliant patients. And, I think that's something, when we talk about, do we have certain access in certain areas, we need to talk about this multidimensional, not just one way. Because when people refuse to go to the doctor when they have adequate care, that's not anything that I can do. We can keep throwing these programs out there all day long, but, how are you going to get people to utilize the program is going to be another thing. But it was a very common occurrence almost daily where people would not go to the doctor's office or to get any type of care, no sonograms, nothing for the entire pregnancy. And I think that's part of the issue. Yes, I understand that there's some deserts and care in the state of Georgia, and that's unfortunate. But, we must also look at what does it cost for an OBGYN and insurance-wise to go to these hospitals. Many of these hospitals can't run these OB programs, even if you have an OB that's willing to go to a small rural area. The problem is the amount of money it costs to run these programs and to insure these programs. That's usually the largest barrier to entry. That's usually the problem. But beyond that, if you have those programs, you can't make people go to the doctor. So does anyone have any comments on that?
This is Dr. Sukas. I would like to respond to that. I agree that the compliance is a huge, huge challenge, and it will probably continue to be a challenge. But there are ways that we can address some of that. Yes, the access and those kinds of things, but I think part of it is being able to provide information about why this is important, what you need to do, how it impacts not only you, your baby, does empower some women to take charge of their health care. And that's some of the things that we are trying to relate to the women. The other thing I think is in some cases, and again, it's not a one size fits all for the entire population, but I think making a personal connection makes a difference. So when we have opportunities to see some of these women in person, when we have family health advocates that are partners with them, can encourage them and help them get through their pregnancy. I think some of those things do make a difference. Again, it's not for everybody, and we're going to continue to have challenges with compliance, but every little thing we can do to address that piece of it, I think, in providing that more personal relationship, I think does make a difference and will change for behaviors for some women.
Yeah, and I think that's great, but I do think we need to have balance. And instead of saying the healthcare system, is letting people down in certain ways, a lot of times we're just sitting here waiting for them to show up. And, we can't make people show up. I mean, there's transportation services that we get. Many times patients they won't use a transportation service. They won't come. And, and I think there's a general mistrust in the healthcare system. Maybe we should focus on that and tell people, hey, you have to come to, your doctor. I mean, this is your responsibility. This is their responsibility as mothers to take care of themselves and their future unborn child. And maybe there should be more educational abstinence and some other things that are out there. But I can tell you, I've never sat around a table and talked about how many Medicaid patients they avoided this week. That just doesn't happen. So, I think looking at this one way and making it look like, to an extent, there's a bunch of bias and a bunch of this other stuff. I've personally not seen that. What I have seen is, nurses upset and crying because they just don't understand why people are not coming to the hospital and getting the health care when basically it's virtually free. And that's the hardest patient population that we experience in rural care to do anything or to have anything done when their care is virtually free. And then you have the mothers that are out there that are coming in to getting their health care, and they know that they're going to have payment plans and they're trying to figure out ways to do it. So a lot of this is about personal accountability, I think, and it's a whole lot less about what our healthcare system is not providing for the citizens of our state. But I can tell you that many of the hospitals that I have been affiliated with that stopped doing OB care, it was just a cost. They just couldn't run those. So, my concern is, great, we're putting a lot of these doctors in these rural communities, but these mothers are still not going to deliver at these small hospitals unless the state is willing to go in and supplement an entire OB program. So, I mean, I think these challenges are going to continue to persist.
Hi, Dr. Richardson Peachstate. I'd like to just respond. And, I agree with you. A lot of it's educational, particularly with the members not coming in, some of our Medicaid members not coming in. Our effort, once we determine someone is pregnant, is to do outreach and do the education and have these monthly, at least, community events. We call them baby showers, to let them know how important it is. I can tell you that many times it's educational, meaning, I'm pregnant, but nothing's bothering me. I'm not going to do anything about it unless there's a problem. I'm an ER physician, and so I've seen those. I've seen people who come in and with no prenatal care, blood pressure's through the roof, and have to put them on mag drips and other things. So I get what you're saying, but sometimes this the mom may have 3 or 4 other kids, and I agree with you. There is certainly a large amount of personal responsibility, but I do think we're going to continue our efforts to educate, to engage, and try to get them aligned with the necessary outcomes. Good outcomes. If they understand that, I think we have a better chance. And again, we've seen some improvement. We'll continue to push more. But your point about facilities, delivery suites not available, I understand that, and it is a challenge across the country in some of the rural areas.
All right, thank you.
And this is Lynette. I'll just add this final comment because I know we're getting close to time. I know that the care management organizations did not specifically address this issue, but I do want to also mention that they each offer value added benefits to try to incentivize members to attend their various doctor's appointments. And typically you see that in the form of, gift cards, or free items or other types of things that they would get access to, whether that's services, vouchers, things of that nature, to try to encourage members to attend their visits and their appointments. So duly noted, and we'll take that back and see if there's more that we can do in that regard. I also agree there definitely is personal accountability that plays a role in this. And I do want to clarify, today's presentation was not at all an intent to, place blame on the healthcare industry at all. Health disparities and addressing health disparities is a national issue right now. There's a huge movement and a huge focus on addressing disparities. And so I do just wanted to close out and indicate that, that is not the intent to place blame or point fingers, but just to draw and shine some light on the fact that there are some disparities that exist out there and the ways in which we are attempting to address them, and not at all removing the personal accountability requirements for the individual. So Dr. Williamson, if there are no further questions, I'll turn it back over to you.
Oh, thank you, Lynette. Really good. As I mentioned earlier, some great presentations this morning. Appreciate Dr. Holloway and Dr. Sukas, Richardson, Darden, all of you making time to share this information with us this morning, and all the effort that went into pulling it together. A lot of great programs that we're trying to address the health disparities that we have. And as Shane mentioned, there is an accountability issue here that also has to play into our solutions as we move forward. I'd like to ask, is there any new business that any of our members have? Okay, hearing none, we will adjourn our meeting and we will reconvene with our DCH board at 10:30. Thank you, everyone, for attending this morning.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you so much. Have a great day.